There are a few of us, but in staying with time, we're going to start at this time. So make yourself comfortable. Take your pen and your pencils and your notebooks if you needed to make notes, as we will be starting this evening's proceedings with Dr. Ravi Raghu. He is one of a member of our pediatric staff of the Southwest Regional Health Authority, currently working in the Peace Filter Clinic in the emergency department. And we welcome him this evening as he does an overview for us on child wellness and then goes into childhood obesity. Let's welcome him.
Hi, good afternoon. Thank you, Dr. Otter. So, okay. So I'm honored to be part of today's discussion on childhood obesity. I know it is something very important, and I would like for us to discuss a little bit about what it is to be a well child. So let's start with our outline. That's all today. Nice. So today is just going to be broken up, my discussion, into three parts. What is the well child? What is childhood obesity? And the implications of obesity on the child. So the well child. Good. So we all are familiar with this definition from the WHO, implemented in 1948, where health is a state of complete physical, mental, and social well-being, and not merely the absence of disease. This is health on a holistic term, but what does it mean to a child? So UNICEF in 2007 considered 6 different dimensions of a child well-being. So apart from just being health, it pertains to material well-being of the child having access to education, family relationships being healthy and promoting the child's well-being, and behaviors and risks of the child. So that's what we're going to focus on, is the behaviors and risks of the child that is in relation to health behaviors, where if they have a meal to eat or not, if they're physically active or not, and any risky behavior that they may be involved in, like violence or being bullied. So as we can see, we know what is the definition of a healthy child or a healthy person. And UNICEF is saying that there's 6 different dimensions of child's well-being. And today we're going to focus on childhood obesity as being where there are behaviors and risks being done to affect this child's well-being. Next slide, please. Next slide, please. So what is childhood obesity? So this is the WHO chart, and it is used to demonstrate how we would tell or diagnose a person or child if they are overweight or obese. So we would be familiar by now with the Z-score lines, and we would look first for the appropriate chart for the patient in front of us. We would decide the age group, and boy or girl, and we would select the chart. We would plot the BMI, the body mass index for the patient, and see where it falls on the chart. Now we would see the lines on the chart where there is an orange line that is 1 and a red line that is 2. These are called Z-score lines, and they would guide us and tell us what the child is at risk of. Now, we always have to remember we are not looking at just a single point in the chart. We're always looking at trends. But at your one visit to a patient, you might be able to tell where they are going. So just as a quick summary, you would see the orange line. Above the orange line, between the orange and the red, is where somebody would be overweight. And above the red line, that's where they will be diagnosed as being obese. Now, these are rough cutoff points. There are different growth charts that are used with percentages and standard deviations, but these score lines are very simple to read. And if you're able to plot the patients on it, you'll be able to counsel them and get them to understand what your concerns are with their weight. So other patients, they don't know what a weight is for a certain child. They would say, well, my child is this weight and I feel it feels healthy. You use the charts to counsel and to get the patients to understand where you are, what your concerns are, to get them to understand what the child concerns are with weight, and teach them about what BMI is. Okay, next slide. So this is just to show you that there are many factors that are involved in the weight and the concerns of this child. And there are individual factors pertaining to this child, which would be the intrauterine environment, like the child might be, the mom might have gestational diabetes and the baby might have been born big, ethnicity, the genetics, physical activity, the diet, the sleep of that child. All of these things would directly affect the health of this child, and in particular, the weight of this child. Socioeconomic factors would be the parental employment, if they have a good job or not. It may affect if they have money to pay for food or not, to pay for healthy foods or not. The educational of the parents or of the child. So the parents, if they're well educated and understand about food and diet and having a balanced diet, they would more affect the child to have a healthier lifestyle, as opposed to a parent who may not understand about caloric intake and the amount of different food groups that they should have. And the household income, of course, if the parents have a certain income, they may be only able to afford certain types of food. As we all know, some of the bad foods are much more affordable and easily available than some of the good foods. And community factors such as housing, school, and this would be like if the school is let's say close to the child has to take a vehicle to go to the school or not. It would be like a distance away. If the child has to walk to school, the housing situations, if this child has space around the home for recreation, things like that. So there are many factors that come together to affect this child. And just as there are many factors that contribute to the weight concerns of a child, there are many ways to tackle this concern that we have with children being overweight and obese. Next slide, please. So we're looking at the worldwide trends of body mass index being underweight, overweight, obese. Now they were looking at trends from 1975 to 2016, and we're looking at the age groups 5 to 19, and they have been noticing rising trends of children's BMI, but it has been plateauing in the high income countries. This is plateauing at a high level. So BMIs are increasing, but they've been plateauing at high. So that's a little silver lining, but they said that it's still accelerating in Asia and other countries like that. So BMI has been increasing. Now this study has shown that with COVID, now COVID has changed everything, and it also has affected what we had been noticing. So that's long-term trends so far, 1975, 2016, 2017. And now we're seeing that COVID has caused sedentary lifestyle, lack of exercise, overeating, depression, concerns that have once again weighed on the child and affected their weight and their health. And now we're noticing that that plateauing effect is not being noticed anymore, and now we're having an acceleration of the BMIs now. Next slide, please. So this is an interesting thing where the Global Atlas, after agreeing in the World Health Assembly in 2013, countries have noticed that this obesity trend, this overweight trend in our children is a concern. They're not only looking at our children presently, but also looking at the future. And these children, they are posing a threat to countries at many different concerns, financial concerns, the health concerns, and the working force. So what they are saying is they came together in 2013 and they said, we're going to tackle this concern, this trend, and we're going to set a goal. And our goal is that the levels of childhood obesity in 2025 is not going to be any higher than they were in 2010 to 2012. So that was their goal in 2013. And the analysis of the trends in these countries, 196 countries, were that 8 out of 10 of these countries, which is 80% of these countries, had a less than 10% chance of meeting this target. That's an amazing number. 80% of the countries that came together and made that pledge at that time could not even meet a 10% chance of meeting the target, and they said no country was better than 50% chance of meeting the target. No country past 50%. That's amazing. We always bring down Trinidad and we always compare us to the rest of the world, but this is across the whole world. Everybody, they're battling childhood obesity and they're all losing it. These are the predicted numbers of children with obesity. Remember, they said in 2025 we want to be back to 2010 numbers. 2020 worldwide 158 million children with obesity. 2025 206. We're not even staying stagnant. The numbers are rising, and predicted 2030 will be twice as much as 2020. So in 10 years, the numbers are going to double. So this poses a serious concern. Now we're looking at child and adolescent obesity risk score. So they calculated what is the risk of children having concerns or problems with obesity. So in the column on the left, they said these are the countries with the highest risk. 11 is the highest number. So 1 to 11, 11 is the highest number. So the Cook Islands and Puerto Rico and these countries, they have 11. They are the highest concerns, and they're going to have lots of problems in their children. Countries with the lowest numbers are countries like Japan, Ethiopia. They have the lowest numbers and lowest risk of obesity in their children coming up. Next slide, please. So then we I took a little snapshot here of Trinidad and Tobago, because the report is an interesting report that you should take a look at. It has all the countries of the world. Trinidad and Tobago, as you can see here, we are in red. Our risk of childhood obesity problems, our number is 7 out of 11. So we're high up in that list. Chance of meeting our 2025 target is 1%. 1%. Now, I found it interesting, these numbers, so we're just going to focus on them a little bit. So what we're looking at is 2010, adolescent boys and girls, inactivity or lack of sufficient physical activity. You see they're in a kind of a pinkish kind of color, 78 and 85%. In 2010, our kids were not active at all. Now coming up to 2016, we're looking at the two age categories, the 5 to 9 and 10 to 19. The 5 to 9 kids in 2016, the obesity numbers percentages were like 13, 14%. The older age group in that same year were 9%, right? So it's saying that a snapshot in 2016, our younger kids up and coming, their obesity percentages were way higher than the ones before, which that is a trend. That is what we're looking at, is that at any time, the younger generations have more and more kids that are overweight and of that concern. That is not the trend that we're going to, and that is why we have 1% chance of meeting our target. Next slide, please. So I just wanted to compare these three countries. We always compare ourselves to the US and UK. So let's look at the numbers, and this is where it looks. It's not we 1% chance of meeting the target, but the United States, there's 17% chance of meeting target, right? Now the risk score, if you look at it, it is surprising because the US risk score is 8.5 and the UK is 7.5. So when you look at us in isolation, we look like we're terrible, and we understand why. But look at these numbers around the world. Everybody is battling, no matter your resources and the education level and all the history that you have. The concern, this childhood obesity and the overweight concern, it is really hard to tackle, and all countries are on the same problem. Could we go back a little bit? One slide. Thanks. So I just highlighted two things here quickly. Is that we were looking at the 2010 inactivity levels, and we were 78 and 85%. They are more than the other two countries, right? However, in the 2016 5 to 9 group, we are actually in between the UK and the US. So we are actually between the UK and US in terms of that percentage of kids that are obese. Next slide, please. So what I wanted to show here is that of the three countries, we were lacking in policies to protect our kids from marketing of food. That's an important thing that we have to pay attention to. I have a 3-year-old, and he's playing games on the tablet, and there are food ads coming up, and he's learning about food that I would not have taught him about, and he's learning about practices of eating, seeing kids eating cereal and thinking that's what a healthy breakfast is. And as a parent and as a doctor, these are things that I did not provide that avenue to a child. and places are businesses are finding ways to get to our children and teach them the wrong thing before we could teach them the right thing. So marketing of food to children has been one of our downfalls in Trinidad and Tobago. Next slide, please. Next slide. So, is there association between food and non-alcoholic beverage marketing? And this was they did a systematic review and meta-analysis of 96 studies, and the food marketing was associated with a significant increase in food intake, choice, and preference. It's something that we know, but 96 studies have been analyzed and showed this, just as we thought. So results have showed that we need to implement policies to restrict children's exposure to food marketing, because they are going to learn directly from the marketing. Implications of obesity. This is a picture to show you that yes, it affects every part of the child. Every part of the body is affected, just as we know. You start from head to toe and you go down. The child could have concerns with depression, low self-esteem, the quality of life, their concerns are going to be low. Cardiovascular, we know about the high blood pressure, the lipids, we're going to look at coronary artery disease. Endocrine, we're concerned about these children having diabetes, concerns with PCOS and fertility. They could have hernias, DVTs. They could have concerns with malignancies. Musculoskeletal, we know that there's lots of extra weight on the skeletal frame. There may be risk of fractures and different concerns with the joints. Renal concerns, of course. GI concerns, children could have fatty liver disease early on, liver failure, cirrhosis, and pulmonary. We know lots of kids could have asthma. There's association between being overweight or obese and asthma, and also they could have sleep apnea. Children could be very could have lots and lots of concerns. These are the concerns that we don't want our kids to be having. It affects their quality of life, their self-esteem, and their quality of life. So, yeah. Next slide, please. So it's another way of showing that obesity affects all the different systems of the body. It's too many to talk about and focus on, but we know that it affects everything, and each one of these issues are concerned. So just two last small slides. The psychological consequences of childhood obesity. Systematic search was done, and it showed that overweight or obese children are more likely to experience the burden of psychiatric or psychological disorders in childhood, adolescent, and possibly into adulthood. So apart from all the other concerns, the genetic concerns and reasons why an adult may have concerns with psychiatric stuff, then we're setting them up from being overweight to have those concerns later on. Next slide, please. And is there association between childhood body size and premenstrual disorders in young adults? And the findings were in a prospective cohort study of more than 6,000 females. They found that a higher BMI was associated with a significantly associated with increased risk of these premenstrual disorders. And therefore, they said that yes, maintaining a healthy body mass index would lower the risk of these concerns. So the implications of childhood obesity, they are widespread. They affect every system. They can lead to a decrease in the quality of life of the patient, and also a burden on the finances of the society, of the healthcare system, decrease the workforce, and it is of concern. Childhood obesity, it is a rising trend, and it is of concern. So thank you for your attention, and let me pass you on to the next presenter.
Thank you very much, Dr. Rabu, for that interesting and thorough overview of childhood obesity and also the components that make a child well as well. It goes right into what Dr. Leela Sukai, who is our next speaker, is going to talk about. And she's going to give us some information on how we can actually manage children who present to us with these kind of concerns in the primary care setting. She is one of the primary care physicians working in County Caroni, but is also the lead physician for our child wellness centers in the Southwest Regional Health Authority. So she journeys between 4 different sites every week to ensure that children across the Southwest Regional Health Authority are given a very needful service at this point in time. I do ask that you hold your questions until the end of all of the presentations. You also have the option of writing in your questions as the presentations go along into the chat box so that we'll be able to answer them for you at the end. So I'm going to hand over to Dr. Sukai at this time.
Hello, good evening, everybody. So my topic today is the management of childhood obesity in the primary care setting. And Dr. Raghu nicely mentioned that the complications of childhood obesity and Southwest Regional Health Authority has taken up the very difficult task, as he just pointed out, of trying to manage childhood obesity in the southern region. So, give me a minute. So what's the criteria for referral to a patient with childhood obesity? Well, he mentioned the BMI charts or the weight for height charts being over the 1 or 2 standard deviations. And how can we get these referrals? Children, most children between the ages of 1 to 5 would be attending a child health clinic. So if a child is picked up as being overweight or obese, that child can be referred from there, or from their walk-in clinics or the accident and emergency, or even from a private medical officer that is not working within Southwest region. How do we evaluate these children? We start off with a very detailed history. Our first assessment is quite a detailed and a long one, and it takes some time, but it's all important. So what do we look for? We actually start all the way back, and he would have mentioned that in the risk that there were birth problems even before birth, things that the pregnant mother would have done that may have caused obesity. So we would have asked all those questions about their birth history, even their feeding history. Even if it's on a bigger child, we'll still ask about what types of feed they would have had, whether they were bottle or breastfed, and for how long, because all of those things affect children and their ability to become obese later on. We ask about the risk of asthma, if they're asthmatic, if the asthma is worsening, sleep disorders like sleep apnea, snoring in sleep, which we find is pretty common in the overweight child. We ask a lot about sleeping patterns, and why is that important? It's important because we found that sleeping for more than 8 hours a day is important, and children who are sleep deprived actually tend to have increased levels of a hormone called ghrelin and less of leptin hormones. And those hormones are what they call the appetite hormones, and they can cause you to overeat and to have increased appetite. It's also found that lack of sleep causes you to lose discretion somewhat, to choose more high-calorie foods and decrease your ability to resist the foods that are not healthy for you. So it's a detailed sleep history is important as well. We ask about pain to the joints because we look for orthopedic abnormalities. And in the females specifically, we ask about menarche, when their period would have started, how their period is, how regular or irregular it is, and whether there is facial hair or acne. And what we are looking for here is the possibility of polycystic ovarian syndrome and possibly metabolic syndrome, right? And a detailed diet history is taken as well. On examination, we would do a weight, height, body mass index, blood pressure. We would look for something called acanthosis nigricans, and that is a darkening around the neck that is found in a lot of overweight children. And that to me is a red flag because it tells us this child has a higher risk of diabetes, and we really need to get his weight down. And most parents present us with the acanthosis thinking that the child has a rash or the child is not performing his cleaning duties properly, and that is why the child's neck or under the armpits are dark. We also assess their gait again, looking for orthopedic problems, which seems to be pretty common. Some of the investigations we do on the first visit is we look at fasting or random glucose, and we do a HbA1c. A thyroid function test as well as a lipid profile is also done. And if we see or we think that there are comorbidities, we may think of doing an ECG or X-rays. Now, how do we approach these children in the clinic? So I think that before the child actually presents to the child wellness clinic, we would have already started managing or intervening to these children. So that's why I have early intervention and prevention, because those things actually occur before they reach the wellness clinic. And then we have the family-oriented approach, individualized assessment and management, and team-based care. And I will detail a little more on it on each slide. So for early intervention, from infancy, we promote breastfeeding. Breast is best. And that is what we promote as soon as the babies come for their 6-week checkup. Sometimes even in the antenatal clinics, we promote breastfeeding. As for the toddlers and the preschoolers, we promote a healthy transition to solids, right? We would have seen a lot of children starting solids sometimes earlier than they should, sometimes not having the right types of solids. Some people start with snacks and sugary drinks from very early on. We also try to teach the parents on the adequate timing for weaning of bottle feeds. I've seen children who are bottle feeding at age 5. So what we started doing now is that even from the child health clinics, from the accident and emergency, from every possible point, we start to educate the parents on when a bottle feed needs to be weaned off. And ideally, from age 1, weaning should start, and aiming to end bottle feeds around 1.5. And if you want to push it, maybe to age 2. Another problem we see is the use of cereals. And a lot of parents, maybe learning from grandparents and great-grandparents and aunties and uncles, they learn to put cereals in the bottle, and that tends to replace a meal for most children. So we are now trying to get away from that and start teaching them that cereals need to be given in a bowl and spoon, and it is really just a transition for a child to learn solid foods, and it should not be replacing meals. For the school-age children, what we try to do is then teach healthy snacking, to encourage less sugary drinks and less sugary snacks, and to teach the parents that there must be now a balance between energy intake, which is their diet, and the energy expenditure, which is their physical activity. And Dr. Raghu mentioned that there has been a decrease in physical activity over the years, especially over the last 2 years. Right, and prevention. So we try again for prevention, and this goes across the board now, from birth straight until we see them in clinic and even beyond. We counsel on healthy behavioral targets. So we talk about the increased consumption of fruits and veggies, increase the fiber in the diet, possibly switching from a low-fat dairy products after the age of 2, and preparing and eating more family meals at home and limiting the fast food consumption. Increasing physical activity to more than an hour a day. I like to joke with my patients and tell them I actually prescribing play, and that's what we're doing. We're prescribing play for at least an hour a day or more if possible, and to limit sedentary time to less than 2 hours a day. Right. So the family-oriented approach. So in the clinic, we do not treat the child as just the patient and the patient in its individuality. Why we do this is because the child does not live alone. The child lives with a family. The child relies on other family members for nutrition and to purchase food and for activity, to be taken to the park and things like that. So we decided that it will improve compliance if children were treated not alone, but as a family unit. And it was also found that in dealing with these patients, that the family members, if you look, most of them may also have weight issues as well. And some of them will also have other comorbid problems like diabetes and high blood pressure. And therefore, all of them will be able to to benefit from the dietary and the exercise changes that we want to implement for the child. So we found that each family, though, we individualize that management. So we won't just tell everybody to do the same thing. We individualize it to the child and to the family situation based on, as I said, the comorbidities and the family's ability to access certain things. Our clinic is based on a team care approach, right? It does not involve just one person. It's a group of us that work together, and this includes our nurses, the doctors, that's myself, the dietitian, the medical social worker. We are also quite close with the child guidance clinic, and in children who have comorbid problems, we refer to tertiary care in hospital. So in summary, let's talk a little bit about our principles for management, right? And as I mentioned before, the treatment goals are individualized, and that is based on their age, on their BMI, on their comorbidities, and also on their family situation. We involve not just the child, but the family and the major caregivers, because a lot of time grandparents and aunties and uncles cook for the children as well. We do frequent assessment and monitoring. Most of these children are assessed almost every 6 weeks to 2 months, right? And we recognize that weight gain is not simply food and activity, but there are a lot of other factors that can contribute to the weight gain. And that's why we are so close to the child guidance clinic, to our medical social worker, because we take into consideration that there are things like anxiety and stress eating and depression that can contribute to children who may put on weight. And we recognize too that children who are in school may suffer from things like bullying and low self-esteem, and we try to deal with all of that in the clinic. And the recommendations for our dietary changes and our physical activities are usually implemented within the family environment, and that should foster optimal health, growth, and development. So what are some of our potential goals? Well, Dr. Raghu painted a very grim picture, our 1% chance. And he's correct. It is a difficult and a slow uphill battle, but we have goals, and we're going to see how best we could try to achieve some of them at least. So for the child who is not yet overweight, that's the child who is the less than 85th centile, we try to aim to teach them to maintain their BMI. Of course, those children will not be in the clinic, but those children will be in the other clinics, the child health clinics, and they would be continuously being counseled as to what to do. The children who are over the 85th centile, right, we try to reduce their BMI to less than that 85th centile, right? And it depends on the age of the child. As I said earlier, it was more of an individualized type of approach, right? But what we aim to do is we aim to have a slow rate of weight gain. So it's not that we have a child with a weight of 30 kgs, let's just use an example, or a BMI of the 95th centile, and we expect that BMI to drop to 85 in a couple months. That is unhealthy for the child. So we aim to do something that is a slow rate of weight gain, recognizing that children are growing, they're getting taller, and BMI is based on weight and height. So if the weight even maintains at the same, but the height is increasing, we can still work to decrease that BMI. Even if we were to look at the charts and we see that we maintain that BMI, if you remember the chart from when Dr. Raghu had put it up, the chart plateaus towards the end. So even if you remain at a BMI of, let's say, 20, as the child grows older, that maintained BMI will approach normal. Right, and for the adolescents, the teenagers who would have stopped the growth more than the little ones, we aim for a weight loss rate of about 1 to 2 kilograms per month, right? But the goal is to do everything at a very slow rate. And why slow? Why do we want something to be done so slowly? Remember, we are dealing with children. We're dealing with children who already probably feel, who have low self-esteem issues, who probably feel pressured because they have to lose this weight. Their parents are probably bugging them. They come into the clinic every 6 weeks and I am asking them about weight. So why do we want to do everything slowly? because it's much more achievable. It's something that they can achieve, and when they do so, even if it's a little bit, they feel happy, and we improve their self-esteem in doing so. Another main reason is that if we decide to drop weight too quickly, these are growing children who need nutrients for growth that can impair their growth and development. And I'm sure people may have seen others or may have been in diets themselves where they may have tried a crash diet, lost a lot of weight, but then found it very difficult to maintain as time goes by. And that's what it was found, that it's better to adapt to a slower weight loss because they could sustain that over the years, and they could take that into adulthood. That type of lifestyle is what we wanted to take into adulthood, not a weight loss lifestyle, but a healthy lifestyle that carries them to a healthy BMI. What are some of our limitations for the clinic? And we've had quite a number of limitations. And one of them is time, right? It takes quite a lot of time for these behavior modifications. Counseling takes time. Parents sometimes don't have time and may not want to spend 2 hours waiting in clinic for a doctor to counsel them, then the social worker to counsel them, then the dietitian to counsel them. So it's a limitation there. Another problem we have is compliance. Compliance by both the child, sometimes compliant by the parents or the caregivers. Parents sometimes who have their 5-year-olds on bottle feeds seem very unwilling to stop it because it seems that it's more convenient for them, or they think that's their baby and they refuse to give it up. So compliance is a problem. Frequency of follow-up. So even though we give 6 to 8 week appointments, people are busy, people have jobs, people have school, and sometimes there are lots of missed appointments. So the frequency sometimes allows people to drop off. And when we see them up about 6 months or 4 months later, we will be starting back from scratch. And the main limitation that everybody is facing, COVID-19. So over the last few years, COVID-19, the last 2 years, COVID-19 has actually increased the rate of obesity. And I have seen it in the obese children, and I have seen it in the ones who were not obese and are now presenting as obese. And what's the cause for that? The increase in sedentary hours, the dietary choices that they made over the last 2 years. They're home, they're not in school, so they eat a little bit more. And our health promotion activities that we would have started 2 years ago would have had to stop. And those things would have promoted activities and diet, and those things were being done in schools and in camps, even the grocery tours, the community talks, all of those things were put on hold over the last 2 years, and they decreased the level of education that we were able to bring to these patients. But all in all, we are still trying. We're still trying our best to get the numbers to look a little bit better. So we should have a better percentage than that, Dr. Raghu, hopefully. So our team will be working with the family team, that's the family of the patients, to get it done. And together we can do it. Thank you.
Thank you very much, Dr. Sukai. Yes, it is a grim picture, but there is hope. There are things that we can do and we can intervene. And as you so nicely put it, when we work together as a team, we would be able to achieve and accomplish much. That team is not just your healthcare providers, but we also partner with families and households, schools and communities to help us along this journey with children and beating childhood obesity. Our next speaker is part of one of our highly esteemed departments at the Southwest Regional Health Authority. And it's none other than our nutritional and dietetics department. They have done tremendous work in this field over the last 2 years and even before. And tonight we have joining in with us Mrs. Marissa Dowrish Prince. She is a registered dietitian, and she's here to guide us through the nutritional intervention for children with childhood obesity.
Thank you, Madam Chair. just share my screen. Good evening. I will be presenting on childhood obesity management through nutritional intervention. At the end of this presentation, the audience should be able to identify the risk factors associated with childhood obesity, healthy feeding practices from infancy to adolescence, and practical solutions to fight against childhood obesity. In more recent times, society has been characterized by unsupportive environments, which feature expanding portion sizes, a wide variety of sugar-sweetened beverages, and high-fat foods, as well as increased screen time. Now, this promotes increased food intake, unhealthful food choices, and physical inactivity. However, childhood obesity can start long before a child is even exposed to these external environmental factors. It can start from as early in the mother's womb. Frequent consumption of foods which are high in sugars and fat during pregnancy can result in the birth of overweight babies who later develop weight problems or associated health-related complications. The key is to prevent obesity by starting early, ideally before the baby is conceived. A healthy, balanced diet before conception and during pregnancy will help to nourish the growing fetus and build optimal reserves in preparation for life after birth. The first 1,000 days of a child's life sets the blueprint for the child's lifelong well-being. So good nutrition and establishing positive eating habits during this time plays an important role in building long-term health. Remember, nutrition now matters forever. For the first 6 months of life, the World Health Organization recommends exclusive breastfeeding. Breast milk contains the most complete nutrition composition in terms of carbohydrates, proteins, and fat, thus encouraging optimal growth in babies. Breastfeeding has been proven to reduce the risk of infection through protective antibodies, reduce the risk of overfeeding, as well as improve or enhance cognitive and motor skill development in children. There are specific instances, however, where breastfeeding cannot be initiated. An iron-fortified infant formula is oftentimes used as an alternative. However, this is costly, requires planning ahead, and does not contain the antibodies found in breast milk to protect the infant from infection and/or disease. Milk alone is no longer adequate since infants have increased needs beyond the age of 6 months. The complementary feeding is therefore important to develop the acceptance of different food textures and tastes and is the foundation for healthy eating habits. You may be wondering, where should I start? Start with items from the staple group such as rice cereals, oats, sago, cornmeal, and ground provision. Then vegetables, followed by fruit. Fruit is sweet, so many times infants don't wish to accept the bland taste of vegetables if given after fruit is introduced. Next, peas and beans and meat can be introduced, noting that healthy fats are to be used in preparation of all the foods offered to the child. Remember, introduce foods one at a time, and it may take multiple tries, so don't give up after the first, second, or third attempt. At this stage, we have the full transition to the family diet. Offer toddlers a wide variety of whole grains, proteins, fruits, and vegetables. They need approximately 1,000 to 1,200 kilocalories per day. While this is so, focus should be on quality, not quantity. Allowing toddlers to feed themselves develops hand-eye coordination and self-awareness of feeling full. It is important, however, to avoid choking hazards such as nuts, seeds, corn, and grapes, or even hard candies. Once your child is old enough to start walking, running, and jumping, we encourage discovery through play and movement. The preschoolers or 3 to 5 year group need approximately 1,200 to 1,400 kilocalories. It is important to model healthy choices, as preschoolers should have the same variety of foods as adults, but in smaller servings. They can tend to be picky eaters, so don't worry about the clean the plate club, but ensure to maintain your colors and varying textures. Avoid high sugar, high salt, and high fat snacks as well. Instead, offer healthy options such as unfrosted cereals, fruit, and yogurt. And lastly, ensure movement by reducing screen time and increasing playtime. Next, in the school age group, growth is slow but steady. Their caloric needs are approximately 1,400 to 1,600 kilocalories per day. Here we continue to offer a balanced diet and encourage children to help in meal preparation as well as the meal planning. Meals should be served at the table or a designated eating space away from the television, tablets, or other devices to avoid distractions. We encourage children to at least get 60 minutes of moderate to vigorous physical activity on most days for good health and fitness and for healthy weight during growth. The teen years are time to grow and change. Hence, the foods that teens eat need to support this process. Here are some ways in which you can help your teenager eat healthier. Arrange for teens to find out about nutrition for themselves by providing exposure to teen-oriented cooking shows, food magazines, or simply supporting their interest in health, cooking, and nutrition. Take their suggestions when possible with regards to actually preparing the meals at home. Limit their purchasing power. By providing packed lunches and snacks as much as possible, you can control what they have available to them. Experiment with foods outside of your own culture, as this piques interest and willingness to try new nutritious food options. And finally, have several nutritious snacks available, as teenagers love to have things that are convenient. Now, adolescents tend to begin to focus a lot more on body image, and this has an impact on their dietary behaviors. So issues that we tend to see among adolescents are skipping meals, excessive dieting, or even binge eating. And this is why obesity is still a concern for these individuals. Just like children, it is recommended that they have at least 60 minutes of moderate to vigorous physical activity. Fighting childhood obesity together works. Protecting the quality of life our children live is a responsibility to be shared by all of us. Whether we play our role at home, school, or as a healthcare professional, or indirectly through sector influences such as the food and beverage industry or through government policy, we have a responsibility to ensure that the cycle of generational non-communicable diseases can be halted by preventing one of the major risk factors, childhood obesity. Let's work together on creating a supportive food environment as well as a physical activity environment for our children so that they can form healthy habits about healthy living at an early age. So what can we do to create a supportive environment? We can create a supportive environment by eating well during pregnancy. We can breastfeed our babies and reap the benefits, including reducing the risk of overweight and obesity. And we can also introduce and repeatedly offer a variety of foods to our children from as early as 6 months. Remembering nutrition now matters forever. There is clear evidence that added sugars, especially sugar-sweetened beverages and high-fat foods, are linked to obesity and other health-related conditions. So it's now even more important that we help our children to understand that sweets and high-fat foods are not everyday foods. Involving the children in meal planning, shopping, and preparation helps not only you to understand what their food preferences are, but it gives an opportunity to teach about nutrition and to encourage them to try a wider variety of foods. We should eat to live, not live to eat. Setting standard meal and snack times helps us to avoid that all-day grazing. The focus at these times should be on portion control, and therefore small frequent meals are recommended. Eating in front of the television or other devices makes it extremely difficult for us to pay attention to feelings of fullness and definitely may lead to overeating. Therefore, this practice is discouraged. Offer more water instead of sugar-sweetened beverages, and provide a safe, accessible place outside for play where the family can participate in physical activity time on a regular basis. Let's protect our children by giving them good nutrition and an active lifestyle today. Thank you.
Thank you very much. Thank you very much. Lots of pearls and nuggets of wisdom there. And again, you would have seen that theme of working together, it being a team effort and not just any one entity involved in how we manage children. And you would also note that before there's even the sign of a child being overweight or having obesity, nutrition is very important from as early as when that child is conceived. We have given you a lot of information this evening on childhood obesity and things that you can do. But we know that another challenge that many persons would have brought to us is how they can actually access services within the Southwest Regional Health Authority. And therefore, to share with us this evening on that, we have Miss Melissa Brayton, and she is going to be doing just that, how to access services within the Southwest Regional Health Authority. So I turn over to her now.
Great. Good afternoon, everyone. So this afternoon, I will be presenting on how to access services within the primary care setting of the Southwest or at the Southwest Regional Health Authority. And while we would have gotten a lot of information on childhood obesity, most of the presenters would have been sharing, and I note some key points that they shared, which was working together as a team and actually accomplishing better healthcare working as a team. So my task this afternoon is to share with you guys on how you can access services through the Southwest Regional Health Authority, not just for your child and dealing with the childhood obesity aspect, which was just shared, but how to holistically access services for the entire family so that the entire family can be healthy. So let's start this slideshow. So I'm just going to give you an overview of the SWRHA, and the Southwest Regional Health Authority is the largest regional health authority or largest regional RHA, which serves a population of more than 600,000 persons. The SWRHA comprises of 31 primary healthcare facilities, or as you would know it as health centers, 2 extended care facilities, and 3 district health facilities. Within the district health facilities, we also have primary care centers within them, which are Couva District Health Facility, Princestown District Health Facility, and Superior District Health Facility. We have 2 hospitals, which are the San Fernando General Hospital, which is also comprised of the San Fernando Teaching Hospital and the new area Point Fortin Hospital. And we have 1 rehabilitative center. So what is the mission and the vision of SWRHA? So in other words is what we do and why we do what we do. So the Southwest Regional Health Authority vision is to become a leading provider of compassionate, cost-effective, premium quality care service to the people of the Southwest region. Our mission is in the business of promoting wellness, which is something that we would have just been doing, which is health promotion, and providing cost-effective, customer-focused healthcare to the people of the Southwest region within the guidelines of the national policy, and ensuring our staff a productive and rewarding environment. Next slide. So what is primary healthcare? So primary healthcare is a whole of society approach or teamwork approach to health that aims at ensuring the highest possible level of health and well-being and their equitable distribution by focusing on people's needs and as early as possible along the continuum for health promotion and disease prevention to treatment, rehabilitation, and palliative care, and as close as feasible to people's everyday environment, which is the nearest health center to you. Next slide.
We seem to have a bit of delay, so I'm just going to
Okay.
restart the presentation.
Sure, no problem.
Let's try this again. Ms. Britton, are you seeing now?
No, I'm not. I'm not seeing anything, but can I present
Or
without the
yes, you
slide?
can go ahead and present, and we
Okay,
will pick back
sure.
up with you.
Okay, sure. So sorry about that, everyone. So we'll just continue without the slideshow for the moment, but just to continue. So primary healthcare services. What are some primary healthcare services within the SWRHA? And this is I wouldn't. It may be a resensitization for some of you that are logged in, and for some of you this may be new. So let's go. Health office. We have the health office, which is all health centers have. If you're not joined into a health center or a primary healthcare center, you can go in on any one of the health office days, and that is where you can register or you can join in to be part of the primary healthcare or the health center services. So what are the services we have? Chronic disease clinic, that is where diabetes, hypertension, etc., thyroid disorders, and those sorts of disorders go to that clinic for. We have antenatal clinic. We have child, which is a clinic where you can, as Dr. Sukai would have, get your referral letter or to be referred into the child wellness clinic. We have family planning services such as pap smears, contraception services for both male and female. It's not done at all of our health centers, but it's at selected health centers. So you would get more information on the centers as we go down. Child wellness centers, which is also at selected health centers throughout the Southwest Regional Health. We have a day where you can go and have your dressings done. This is where if you would have had a surgery or you would have had an injury and you need to go get it dressed, or actually a service that you probably don't know, that the DHVs actually teach people how to get their dressings done and when and how often they should remove and take care of their cuts or their bruises. We have adult immunization as well. So if you need to get any of your vaccination, not just COVID-19 vaccination, in case you may need yellow fever, we have HPV vaccines available for adults as well as the teenagers. We have as well the tetanus immunization, which is done at the health centers, but those are done on specific days. So you may have to call the health center to find out what days that they actually offer those services, and you can go get your immunization. We have pharmacy services as well. Pharmacy services are not for private prescription, and that is if you go to a private doctor and you get a prescription, this SWRHA does not fill that prescription. The prescription must be done within the Southwest Regional Health Authority umbrella. So if you would have gone to accident and emergency, you would have gone to any one of the health centers and you were given a prescription to be filled, that is when your prescription will be filled within the authority. So just to give you a brief idea of some other services that the Southwest Regional Health Authority primary healthcare setting actually offers is something that we call SPOG clinic, or a specialist obstetrics clinic. At this clinic, you are referred to this clinic actually if you go to antenatal clinic and they realize that you need to be treated or you need to be seen with a little more care and concern. They actually refer you to this clinic. This clinic is actually done at special health centers as well. So it's only done based on a referral basis. Mental health clinic, same thing. It is done based on a referral system, and it's only special health centers actually offer that service as well. We have a smoking cessation clinic, once again, and I'm calling out this list, and this list is where it's special services, and by special it means that you have to be referred by any one of the clinics to this clinic, which is either a follow-up care or a little bit more interactive care based on your level of concern or medical management, that is. We have a change of catheter clinic. We have childhood development clinic as well. Like I said, all of these are referral letters. So when can you access services within the Southwest Regional Health? Either by a routine visit, either once or twice a year for appropriate screening and general review. If you have any medical or health issues that does not require a visit to the emergency department. So what are some of the things that you actually visit the emergency department for and not a health center? So you can visit our emergency department if you have a severe chest pain, if you have severe abdominal pain, if you were in a motor vehicular accident, if you would have been shot or there's a gunshot wound or chop wound, a near drowning experience, allergic reaction, or asthma attacks. And there are also a list of primary healthcare services, or why you should access primary healthcare on the Ministry of Health website. You can go there and click the link and they would now guide you through when to access primary healthcare services, because the list is exhaustive. So you can go there and get a little bit more clarification. So how to access primary healthcare services? So you can walk into any one of our 31 primary healthcare centers between the hours of 8 a.m. to 4 p.m. Monday to Friday, and you can speak with either the DHV, the clerk that is on duty, and they would actually tell you when and give you an appointment of how to access the services. So because of time, this is all that I can present at this time. So if you have any questions or concerns, or there's anything that you want to find out that's happening within the Southwest Regional Health, you can visit our Facebook page at SWRHA, I believe it is, yes. But you can go to Facebook and Instagram at any one of the handles, and you can be updated on SWRHA's every move and everything that's happening within the Southwest Regional Health. You can also call our customer service call center at 87 SWRHA. That is 877-9742. It's a toll-free number. So even if you don't have credit on your phone, you can call them and ask them, hey, I need to get to this clinic. Can you tell me if they are open? Or can you tell me where I can access this particular service? And they'll be able to guide you accordingly. Or you can send an email at customerservice@swrha.co.tt. That is customer service, all lowercase, at swrha.co.tt. And like I said, should you have any further questions, even after we close off this seminar today, you can always call the 87 SWRHA number and you can ask any questions, or they can take your information and they'll forward it to the relevant persons, and somebody will get back to you with the relevant information and guidance that you may need accordingly. So thank you so much for your time and listening to our presentation this afternoon. I'll hand you back over to Dr. Arthur, who would continue with the presentation.
Thank you very much, Ms. Breton. One of our dynamic staff members, accommodating and ushering and showing persons how to navigate their way through the different services of the Southwest Regional Health Authority. Thank you once again. We are now at that time where we go into our questions, and there are a few we have so far, and we thank you for joining in once again and for actually participating. So the first two questions are from Ms. Indira Patel. Number one, does childhood obesity affect kids with ADHD? I noted it was impossible to go through the many ways the child will be affected by obesity. Just curious to know. So she's curious to find out if childhood obesity would affect children with ADHD in any other way apart from what we would have discussed before. I will ask Dr. Raghu to address that one for us, please.
Hi, good evening. So childhood obesity and ADHD, there is a link between childhood obesity and autism and ADHD. It is where healthy eating and healthy practices have to be taught and understood by a child. And a child that has behavior concerns and learning concerns, of course, getting that message across and getting them to understand and follow healthy eating practices and making choices that are what you want them to make choices are, it will be more difficult to focus these kids. So in clinics in community pediatrics, we are seeing an association between ADHD, autism, and obesity. These kids, let's say the autistic kids, also they have their ways that they want to eat and things that they want to eat, and a lot of the parents they just give in because the children are difficult to manage. So ADHD child might only want to eat or drink something that you know is wrong. It might be a sugary drink or a snack, but the parents would be, let's say, dealing with so many different challenges throughout the day, and they may just let the child eat or drink what they want. So yes, there is association with unhealthy eating practices and as such overweight and obesity in this medical illnesses. Yeah.
Thank you, Dr. Raghu. The second part of that question, I will ask our dietitian to address that. Have we made any headway with packaging and making it neutral, not directing the marketing of high sugar foods to kids? Just remember to unmute.
Hello? Sorry
Yes, we're
about that.
hearing you
There's a
now.
delay. All right, thank you for your question. The World Health Organization, along with the Caribbean Public Health Agency and the Healthy Caribbean Coalition, has recommended a comprehensive approach to childhood obesity prevention, which includes taxation of sugar-sweetened beverages, regulation of marketing to children, mandatory front of package labeling, and school policies, healthy school policies. In terms of what is being done on a Caribbean level, I know that in 2021, the Healthy Caribbean Coalition had a campaign entitled "Now More Than Ever, We Need to Protect Our Children." And the idea of the campaign was to promote overall health and well-being in children and young people while building that support of that healthy environment and focusing on the increased access of nutritious foods. So what we are having is all the member state countries in CARICOM were challenged to participate in this campaign and mobilize their efforts to do just what you're asking, make things neutral and focus on redirecting the message from marketing of unhealthy foods and beverages to marketing of healthy options. As it relates to where Trinidad and Tobago is currently, we have only been able to implement the ban on sugar-sweetened beverages at schools. I know there is heavy work being done into the nutrition policy or guidelines for healthy school eating. And in terms of the regulation with regards to the front of label packaging and the marketing, those have not been initiated, but they are in conversations. So to answer your question, we are moving slowly, but moving.
Thank you very much. Our third question is from Sastrin Dean, and his question is, what are the pharmaceutical options for helping manage childhood obesity? I think more than one of our speakers may like to tackle that. So I'll start with Dr. Sukai first, and then if Dr. Raghu wants to join in, he can do so. So Dr. Sukai.
Right. Hi. Thank you for that question. At present, we have no pharmacological treatment that we use, at least in Trinidad yet. I think in the US, the only one that has been approved is Xenical, which is Orlistat. That's only for ages 12 and above, but I am not sure if we are using that yet in Trinidad. I don't know if Dr. Raghu will be able to answer that.
Yes, we don't
Thanks,
use
Dr.
any medicines in our practice here for the kids. We don't currently.
Okay, thank you very much. Okay, so Ms. Patel said thank you for the responses. And also, I'm not seeing any more questions at this point in time. Does anyone else have any questions that they would like to pose to our panel? Feel free to enter it into the chat box at this time.
Can I mention one thing?
Sure.
About the question about the packaging of foods. It's something that I am very aware of as being a parent and just being conscious about the way food is packaged and the calories and serving size. And I looked at a recent documentary about one of the chocolate factories, the ones that has the purple packaging, and they have come out with a bar. I don't know if you have noticed it. It says 40% less sugar, and they're promoting themselves as making a healthy choice. For those of us that enjoy chocolate, we could have a less guilty version of it. And the documentary was followed by some impartial, they were unbiased reporters, and they keep asking the guys, is it healthier for us? And they actually tweaked it and made it way, way fattier. And it's not healthier for you, but they can state on it, it has 40% less sugar. And they're making a bar that's worse for you. And people need to question, if something sounds amazing, then something has to be wrong with it for the bar to taste the same and give you the same feelings of eating this chocolate, something has to be off. And they've been using a whole batch of scientists to come up with this formula to, because I enjoy that chocolate, right? And it's one of my guilty treats. And when I saw 40% less sugar, I was like, right, cool, we'll try it. And I did research and I looked at the documentary. I was like, this is cheating. They're marketing a bar as 40% less sugar, but they're actually making it worse for you. And they're laughing in the video because they know they're fooling us all. And that's what we are fighting. And that's why my presentation was grim 1%, because they have all the money and they have all the resources and they are winning on their side. So because kids are being they're being drawn to the even packaging that we are not there in the grocery and the kids are seeing it and the parents will say, yes, take that one is less sugar. Yeah, I mean, yeah.
Well, I saw Miss Dower Springs come up, and I know she's going to talk about something very important now, so I will hand over to her.
Yes, I thank you for raising that point, because I think many of us have not focused on reading food labels enough, and many of us don't know how to read food labels, which is something that we spend a lot of time doing with the kids in the child wellness clinic. And even with my chronic disease patients in their clinics, I spend a lot of time because we don't know what we're eating. If you think back to the last slide I believe I had, there was a spoon of sugar going into a child's mouth, but over the spoon had all of the sugary beverages that they possibly would have been drinking. And you know, we wouldn't be giving our children a spoon of sugar or 2 or 3 spoons of sugar to consume, but that's exactly what they're consuming in those packages. So I think really and truly we need to spend a little bit more time educating ourselves on reading food labels so that we can adequately make choices. That is pretty much the main thing. Now, another challenge that we have is mainly that these companies tend to sponsor a lot of the events that children do. So we have a double-edged sword. You don't have finances, they come to your rescue with funds. But on the other end, you have that free marketing that happens. So it's always in the kids' face. And I don't want to call any brands, but pretty much all of those multi-chain companies, they offer stationery, they offer free meals after SCA, they offer everything that you could think about to get the children. Even in the grocery stores, if you look at how the snack aisle is packaged, most of the things that are unhealthy are packaged at eye level of the child, not the adult. So it's always a very strong marketing game that we are combating. And this is where the grocery stores come in. So when Dr. Sukai and the dietitians like myself go into the grocery, we spend a lot of time training the public on how to look out for the ills that might put them in more danger.
Thank you very much. We're learning this evening. However, we've come to the end of our time. We thank you for joining us, and we want to remind you that we're going to be here discussing different pertinent issues on the last Tuesday of every month. Coming up in June, we're going to have a discussion for women. That's going to be exciting. It's going to take a bit of a different format, but we promise that it will still be informative. This meeting was also recorded, and therefore, for persons who are unable to join in, that would be made available by request. So we thank you, and if there are no other questions, we say good night to you, and do have a restful and enjoyable evening.
Good night.
Good night.
Mish